now that's kind of bringing us to the end of the presentation section of today's event. But we do have time now for a panel discussion. Um, so while we're kind of bringing up, hopefully technically we can bring up the panel of all of the speakers today so that I can ask them all some questions. But while we're doing that, I guess I wanted to firstly thank all of our wonderful speakers today who have done a brilliant job and really, demonstrated a great breadth of research topic areas, of research methodologies, and really demonstrating how we can look at this, look at caregiving from so many different angles. It really did highlight the value of collaborative, carer inclusive research, and the importance of ensuring that research continues to inform meaningful policy and practice and healthcare. And I think that, the work that is being done across multiple institutions, across multiple health conditions and from different lenses is so exciting. And as a researcher who can't call herself ECR anymore, sadly, but I'm so thrilled that our area has the likes of the five of you working towards these important solutions for big issues. So I'm going to hand over to Kira, who has got a couple of questions for you, and then I've got a couple of questions. But I guess, we don't want to put you all on the spot, but if there's anything that you do want to contribute to this discussion section, please feel free. We'd love to hear your thoughts. So over to you, Kira.
Thanks, Beck. Yeah, please jump in. My first question is around gaps in the evidence base. Specifically, what are the biggest gaps in the evidence base that your work is really trying to address? Any first takers?
I can talk specifically, I guess, about M&D.
Yeah, great.
And that obviously with M&D, it has a very, I guess, medically and research trial based history. So from M&D's perspective, there's actually quite a gap in qualitative research and co-design. So obviously, I think that's very important to hear what caregivers have to say about things. So that's, hopefully something that my research is contributing to a little bit, I guess.
Yeah, that's really interesting. Did anybody else have any perspectives on their work and the gaps that the evidence base is trying to fill? Obviously, motor neuron disease is quite specific with that medical background, as you mentioned, Sally.
I think about gaps as a whole, in terms of what kind of gap my research is filling, the fact that very few resources and research as a whole actually looks at carers seeking support for themselves. Within the literature, there's a lot of support around, seeking support for the loved one or seeking support for physical issues or practical services and things like that. But there wasn't a whole lot. It's actually focusing on seeking support for the emotional needs and for themselves specifically. And I think that really showed up within our systematic reviews that we conducted, where we had to, like, some of the studies that were included, there was about 25 or so in each review that we did, but some of them would be like tiny little just fractions of evidence that would be like, that's what we have to work with. Like, it wasn't necessarily whole studies that were focusing on the particular topic. And I think though my research is focused on cancer, we did notice within our reviews that cancer was the biggest focus. Over half of the studies that we included were on cancer for the systematic reviews, and we looked at support seeking among all types of chronic health conditions. But there were no studies on M&D. I think there was one study on chronic kidney disease or things like that. So I think that just also points to areas that can be improved for other types of carer subgroups as well.
Yeah, definitely transversing a lot of different areas there, even though that the focus might not yet be reflected in the publications that have come out. Yeah.
I was just wondering, obviously I'm more new to the research process, but I guess something that came up for me was wondering in terms of gaps about carers that actually are involved in research and decide and where the research comes from, the the population of carers that are more likely to engage in research. So there might be like another more invisible like population of carers that are struggling but are not, their voices aren't being heard. Like, how do we access that kind of population without obviously being, invasive or so that's just something I was wondering when I was like conducting my study as well, and maybe if anyone has some thoughts on.
Yeah, just to build on that, that's a really an interesting point because overall, the kind of broader gap here in our study is about the sheer lacking of evidence in terms of how carers end their care, but also just drawing on what Theo was talking about. Most of our carers participants are of certain age, and they're in a very specific kind of demographic, as I said, 50s, 60s, which is consistent with the overall demographic landscape of informal carers in Australia. We're not hearing a lot from young carers who experience quite significant quite significant differences in terms of the challenges they face because they navigate a lot of different things, different financial perspectives, different employment challenges, school, university. So yes, there are definitely many other kind of groups that we're not hearing about. For example, also carers with disability themselves. There are a range of yeah, I would say, and we are definitely less likely to hear from them in our traditional research approaches. Yeah.
I think that's such an important point to think about. Who are the people who are not participating in our research, and how is it that our research might not be reflecting the bigger picture? And for sure, like the experiences of younger carers. We've just finished in our group a big trial of 300 cancer carers, and I'm also struck by sort of the absence of, or not absence, but the lower proportion of male carers that we have participating in our research. And I often wonder, is it the way that we're advertising it? Is it are there other barriers that we need to think about? Because I guess there's probably these cohorts of carers that we're not capturing their views, and therefore we're not, developing interventions or mapping out services or making policy recommendations that reflect their voices. So yeah, there's a lot, I guess, for us to think about in our recruitment methods and the way we advertise. I guess, am I allowed to, Kira? Is it okay if I I'm going to throw a random question out there, if that's all right, just
Go
to
for
springboard.
it.
I'm curious about recruitment. And I guess talking, it's lovely to have a room full of researchers where we're talking about recruiting carers, because I think it's a real challenge. It's a real challenge. It's, we've got lots of different recruitment methodologies, I think, that we've talked about. So Thea with her international sample using Prolific, but then, what are the some of the question marks or challenges of when you engage with those sorts of research platforms. We've got community organisation recruitment. Anna, you were recruiting through clinical services. Is that right?
Yeah, and I guess that's probably maybe the one benefit to being a clinician researcher as well is, the ability to develop a project when you're working in that space and your access to sort of people on the ground and people to approve different things. And whereas I'm mindful that for others it's not as easy, and also sort of having the knowledge of how different things work in that space in terms of recruitment and how you could sort of insert yourself for recruitment easily. So that has definitely been one of the benefits of sort of working in a service that I'm, then also a researcher for, but has its own sort of challenges as well. And sort of
it does. And I think that, across all of our different strategies of recruitment, there are probably pros and cons. There are opportunities and there are things that we have to manage. I know that, for example, Kira and Hannah and myself have been using Facebook and Meta advertising. But that itself has challenges. And I think there's this tension that I'm always cognizant of, and I'm interested in other people's perspectives on this, of, reimbursement of carers' time. But then also sometimes I get people signing up to the study, and they're very, very quick to ask me, what's the reimbursement? How much is it? And it does start to raise alarm bells in terms of, are these genuine participants? And I don't know how you all manage that, and how, collectively as a, community, we make sure that we give carers recognition and reimbursement where possible, wherever possible, but then also manage the challenges of inherently digital advertising and the sort of methodological complexities that come with that. Any thoughts?
Well, Beck, even I was just thinking about how even with like Facebook advertising, how we've had such a range from the co-design recruitment where we hit our target number of participants in like 48 hours versus recruitment, exact same methods and strategies for the pilot study, and it's taken months to hit like the same sort of thing, and just how much variation there is. But I guess even in that, with just the nuance with which we're going about the advertising, of rather than advertising these things for like carers, advertising it for like the family friends, like, oh, are you supporting a family or friend with cancer, or are you supporting a family or friend with MND, or something like that, of just looking at that more supportive role. Yeah, and just kind of that role in that. And I've definitely had some where they come up and they're like, oh, what's the reimbursement? And I'm like, nothing. And then I won't hear back from them. And that's not to immediately say that they're like scam participants, but it is just that interesting thing, and how many still actually get to the end. And I thank them for their time, and it just actually taking the moment to acknowledge their contribution to our research, and how many of them come back just being like, no, like this actually gives me so much meaning. Like it helps create a sense of meaning. It helps me feel like I'm helping at least one other person who's going through what I went through, or helping contribute to something so that they don't have to go through what I went through. Like I think, yeah, there's that strange tension. But also, if I can just jump back to what we were discussing earlier with some of the like kind of more hidden carer populations, for our co-design process, the benefits of us actually having professionals as well as carers when we were developing it is that some of the professionals were able to then share insights into some of the carers who wouldn't necessarily sign up for our studies. So the health literacy, not just mental health literacy, but health literacy as a whole, is a really big thing that was brought up among professionals, especially for those of like non-English speaking backgrounds, or like that sort of kind of culturally and linguistically diverse populations, and all those sorts of things that the carer participants never mentioned, because they were often highly educated, English speaking, all those sorts of things. But I think there's that benefit of, even if we can't necessarily get those target populations specifically, trying to almost get creative in other avenues of perspectives of like, okay, what are the clinicians seeing? Like, especially the social worker perspective that we had of like, okay, what are the social workers seeing? What are the clinicians seeing of like the groups that are not necessarily having a voice within a lot of these research studies, but how can we bring a voice to them in like different avenues, if that makes sense?
Absolutely. I think that's such an important technique and strategy for being able to capture, and something for us all to be cognizant of is including those other health professional, allied health professional, and perhaps also thinking about, I'm just thinking through in my head, we're recruiting at the moment for honours students, and one of those honours students is recruiting health professionals. And I'm thinking through, and I'm like, well, making sure that we can get at least diversity in our health professionals of where they're working, the types of communities they're working, making sure that we're, not just interviewing the health professionals who are in tertiary referral centres, but, making sure that, because they can, whilst it's not as, it might not be as sort of close to the needs of the carer if we were to interview the carer, interviewing health professionals who are working in rural and regional areas, or who are working with young populations, that those sorts of things might be able to help us. Yeah. I'm going to ask, sorry, Kira, I'm so sneaky. I'm going to ask one other question, then I'll hand back to you, because this is just a little thought bubble that came up where I want to talk about publications, and I want to talk about where we publish. And I guess I think that one of the things that I've discovered I started back in 2010 doing carer work. And I discovered that there was huge fragmentation in our evidence base. Because I think, in large part, many of the journals that we probably all publish in are condition specific. So I'm not sure about you, Sally, but maybe you're publishing in in MND or neurological related journals.
Actually, my caregiver paper actually is currently under review at Disability in Rehab, which I think has a broader scope.
Disability. Yeah, that's really interesting.
But I was actually limited in M&D specific journals just because it was a qualitative study and the word limit. So sometimes with disease specific journals, yeah, qualitative research can be limited because it does have
Yes,
that longer word
such
limit.
tight word limits. That's right. But I think that's one of the challenges, right? Is in our caring, community of researchers. Sometimes we're quite fragmented, even though we're all doing work that it sits in, great alignment and we can be learning so much from each other across conditions and disciplines. But yet sometimes we're probably publishing, and that speaks to exactly why things like carenology, because, we oftentimes we are publishing potentially in fragmented areas. I know that I'm not sure, Anna, if you're planning on publishing your scoping review anytime soon,
Yes.
and where you're thinking about publishing it.
Yeah, so this was a big area to sort of think about, and we actually decided to submit it to palliative medicine because of its impact factor, and we've just had our editor's comments come back, so we're looking to respond to that, which is
Right.
really great because probably equally to Sally, it's sometimes a bit hard with qualitative studies to get a journal to really think about their impact in the space and how important they are as well. So yes, we're sort of really happy that they've come back and said that. And I guess I was looking to find the journal that would sort of give as much opportunity to educate clinicians as possible, and felt like that was probably the best place for it.
Yeah.
But there's other options, of course. Yeah.
Yeah, fantastic. I think it's that's why, bringing us all together is so crucial, isn't it? That thinking about, all of the different all the different areas that we might be working in, and as Deb's mentioned in the chat here, you know, making sure that you then connect back with Care and Knowledge Exchange, because they can then disseminate and put your publications so that we can all see them and learn again from each other. And exactly why we're doing this is because this kind of collaboration is so crucial. And all right, Kira, I'll stop throwing in random questions, and we can get back to your questions.
No, that's great, Beck. And I think it's so important. There's so many synergies between the different areas, whether that's the different aspects of the care trajectory or the different, disease types that people are caring for someone with. I guess my next question is talking about engaging carers in research. And of course, we all work with carers in different capacities, but I would be interested to hear about people's reflections on engaging with carers meaningfully, as participants or as partners. How do you involve carers in your teams and those types of things?
Come on, someone jump in.
I mean, I'll jump in again. Mine was easy because the approach we did was a co-design approach. So we worked with obviously the professionals, but the carers as well, and we were open to a whole. We obviously came in with the format just to make sure it was still empirically based, but we got feedback on the language, the look and feel, the design, the length of the resource, the content that was mandatory versus optional, all those sorts of things. But along the way as well, within the Psycho-Oncology Cooperative Research Group, we have a consumer stakeholder advisory committee. And so along the process, before we started interviews with our professionals and also before we started interviews with our carers, we had one of our wonderful consumer advisory reps come in and look over the resource and provide her feedback as well, just to provide that extra lens and way that we could make sure that we're collaborating with her. And she's going to be one of the co-authors on the paper that we're publishing. So yeah, just simple little ways to try and incorporate that.
Yeah.
And I guess, Hannah, can you comment on how you've engaged our consumer advisor, and I guess how you're then, reflecting her contributions, in authorship or those sorts of things.
Yeah, so Juliet has been wonderful. So we first reached out to her and just explained the project to her to see whether or not she would be interested in reviewing it. She was very open to it, provided feedback on some of the content and things like that, or some things that she was like, she was great. She was like, I'm not sure whether or not KRS will say this, but I have a feeling this will be their feedback. And funnily enough, it was similar feedback to what she had suggested along the way. And then, yeah, engaging with her again for that next round of things. And then she reviewed the final manuscript, offered her input on some of the language of the resource and everything like that. And then, yeah, is going to be a co-author on the paper, which is very, very exciting. So she's been a fabulous contribution, and has definitely offered some fresh perspectives that kind of we along the way were like, oh, we didn't think of this, and kind of almost helped tease out some potential issues before we took things to carers and recruitment and things like that.
I think that's it's such an important part of research, is having consumer advisors whenever you can have a consumer advisor, and particularly having them in that end to end.
That early on period.
Yeah. Thea, did I see that you were going to say something?
I was just going to add something that I really liked about what Hannah was saying in the resource that she was sharing carers can access, was that not only were you getting feedback from the carers in terms of how the resource was like portrayed, but also within the resource you give carers choices and preferences about what sort of support they're looking for. So it's kind of like double tailored, like the resource itself and then also the resource. So I just think it's really nice to give carers like a voice and allow them to feel like they are an active and collaborative member in their own caregiving, the world of caregiving and the healthcare system. I think that's really important and would be really appreciated by carers. So I just wanted to...
Yeah, that's wonderful.
For us, it's about on top of that, offering information, knowledge. We try to build this kind of meaningful connection with carers throughout time. We try to, I guess, on different levels, from small things, whether carers, when during recruitment, carers might take a very long time to respond. And this, it's a really minor thing, but also requires this kind of patience and understanding. We will have carers actually getting back to us after 3 months because things just went downhill during that time. From those small details in terms of, for example, rescheduling for interviews, and to bigger things, as in, as I mentioned in our study, we follow up with carers and we establish and cultivate a kind of long-term rapport with them, so they get a bit more comfortable each time, because a lot of their experiences are very complex and potentially traumatic for them to retell that kind of story to researchers. They're all very happy to share in terms of using their lived experiences to shape understandings and knowledge production, but also we try to be a bit more sensitive to that. Like in our interviews, we say, well, if this part of the story is you don't want to tell this part of the story, that's fine. The other thing is about, I guess, recognition. So some carers, again, is part of a messy kind of terrain within qualitative research as well, in terms of how participants would like to be recognized. We do provide compensation for their time, but it's not, as we know in research study, that's often not massive or not that financially Yeah, so some more participants act in the role of care representatives with various organizations. Some of them would like their name to be included in publication, their real names. We, of course, take very careful approaches to do that in terms of identifying information and everything else. But just acknowledging that carers have different preferences and different ways that they want to be acknowledged, rather than taking a blanket approach to say, "Oh, we're anonymize you all." It's kind of also about giving them the option. And in terms of the timeline, that research activity we design, we always say, what matters to you matters to us, that we don't give a predefined kind of area of knowledge that we're seeking for. We engage with them in the ways they want to.
Yeah.
Those are all such great points. I think just to jump in and add something as well that I've noticed in my own research is also closing that loop at the end of a study for those people who wanted to receive information or feedback about the study and the actual findings. I've had some really lovely comments and questions from people about what happens next or where does it go. And so providing that final summary and report and offering that opportunity to ask questions as well, I think is something else that I've been reflecting on and noticing lately. But I think those are all such key pieces of information and feedback that we can incorporate into our own studies when we're thinking from the very beginning in terms of timelines and even those types of things. Yeah.
Absolutely. Absolutely. Awesome. Thanks, Kira. Should I move on to our next question?
Yeah, of
What do we
course.
think? Yeah.
Happy to, yeah.
Okay. So we've talked a bit about this, but I guess I'm interested in sort of the challenges of translating your research into real world impact. And I guess that's one of the challenges that we will all probably face for the whole of our careers. But I guess to throw it over to the group, are there any specific challenges that you want to sort of highlight or talk about in that translation piece, in translating what you've done, be it a quantitative study, a qualitative study, a pilot study, sociological work? Like, what are the challenges from moving it to then real world impact?
I think two things are a huge challenge. I think complexity. Complexity is a big issue. Taking your findings and actually applying them to real world methods or interventions often is challenging, often because things are interconnected and span over many areas. And so trying to put an intervention in one area, it may fail because of something that's happening elsewhere. I think that the second big one is funding. It's always going to be a challenge to get funding for the interventions and your research findings. And I think that's just, a consistent problem with research in general, unfortunately.
Yeah. And it's probably something that we have to continually adapt to and get creative about in terms of funding sources and the way that we talk about our research projects and the way that we approach, both the traditional sense of trying to find funding. So I guess, the fellowships or the, category 1 grants, but then also thinking about alternate avenues of funding like philanthropic funding, which I know is becoming more and more of an emerging area for us to all be, have our finger on the pulse of, because it's a big social issue. And I think that people do want progress in this area. It's just about finding, connecting, the researchers to, potential funding opportunities. Anyone else have any other challenges that they want to talk about?
I wanted to mention that particularly in the bereavement space, I think there's some research to say that clinicians are worried in terms of like providing bereavement follow-up and grief follow-up with people that they've known for long periods of time or been working with for a period of time. no matter what it is, that they're worried about opening a can of worms that they won't be able to navigate themselves. So I guess it's about, thinking about how you empower clinicians to recognize their skills in that space and give them the information that they need, and sort of talk through, if it does become a can of worms, how you might look at sort of containing that, and what options you have as well. So that's something I'm thinking about sort of later down the track when I think about the implications for my research too.
Absolutely. And I think that the attitudes and climate and culture among health professionals is such a key piece of this puzzle. There's no one solution, right? Like, I think that that's clear. There's big picture society things. But there is also cultural elements within healthcare teams that act as barriers to even because I think you're right, like that there is this barrier of opening a can of worms, and therefore, does that mean you don't check in just even ever so briefly? And I think that robs so many carers of just small moments of connection that never would become big hours long issues. But that I think that is such an important piece of this is how do we empower our healthcare staff or other support, staff to check in with or reach out to, to a carer, particularly to a bereaved carer. And how do you, I guess, make sure that it doesn't turn into a can of worms? And that's about education and skill building, isn't it? That we can give them. Yeah. Okay. Anyone else this is, sometimes it's just even quite cathartic to go, oh, your problems are the same as my problems and we're all in it together. Anyone else have anything else they wanted to kind of share?
I feel with translation, I really appreciate what Sally mentioned about the complexity as well, in terms of how do we meaningfully engage with those findings and translate them in without liking the nuances that Keras has presented to us. And also, I think the other thing is about the inherent kind of multidisciplinary nature of care research or caring research. That I think Care's knowledge exchange today offers a really great opportunity to gather us together, despite that we have different research focuses, but gives opportunity to kind of, as what Beck just said, to show that we have quite similar problems and quite similar challenges. The other thing with translating, I think, together with that multidisciplinary nature of care and research is speaking different languages to different people. That we so with carers we have kind of a care research bulletin that we translate this in our findings into easy access, public level kind of language to engage with carers to communicate those findings. But with policy makers or support organizations, that requires a whole different kind of language and skill set to do that. And that also requires different sectors involved in caring to talk to each other, to think about the potential implications and how would these suggestions manifest in different sectors, different contexts. So yeah, there's a requirement for efforts in collaboration within academia as well. Yeah.
And I think you speak to such an important point for all of us to be kind of aware of and build our skills in as researchers around how do we communicate our work to different people who will see the value of the work or that have different perspectives on what it is that work means for them. And for each of us learning, the skills of how do we disseminate that to carer populations and the importance of that, because it continues to build trust in our research, and it can close that loop on, you know, why people are even participating in research, and also it helps carers to actually learn from the work we're doing. But then how that does need to be different then to what we're communicating with policymakers, other researchers, to clinicians. I have no doubt, Anna, that you'll be, you know, communicating with your colleagues, the doctors, the nurses, the paramedics, the, you know, OT teams, all the different findings, and that, you know, you'll have to do that in a way that's probably quite different to how you would communicate it to other audiences. Yeah, okay. I guess, does anyone have anything else? I do have a question. Maybe we'll go to the next question, which kind of dovetails nicely. And I want you to all pretend like Jim Chalmers or Albo or someone else has joined the chat. And if you could influence funding or policy priorities, you know, that you're granted a sort of a wish, what are your thoughts on investment? In the carer space? Do you have thoughts? Do you have ideas? Where do you see some of the key pieces of support and initiatives in supporting carers?
I think greater recognition of caregiver roles, and
Mm-hmm.
in some cases that obviously is fiscal, because
Yes.
carers are absolutely saving the government so much money, and we need to see some kind of reflection of that.
Yes, 100%. Yeah, absolutely. So fiscal and recognition more broadly, but then within that is that financial reimbursement, because you see those estimates of how much carers save our healthcare system. Is it 80 billion was a year, which is just so much money. Anyone else? Come on, got that genie in a, you know, that magic lamp. Is there anyone else got thoughts?
I was wondering about, you know, everyone kind of today has been speaking about carers of people with, you know, physical illnesses. And I was wondering about how, you know, we could maybe direct research towards carers of people with mental health conditions, because I imagine there would be like a lot of stigma in other ways for people caring for those that are living with mental health conditions, especially them may not, you know, see themselves as a carer, because that term tends to be used more with like physical health. So I don't know. I wondered how that could, you know, the themes could transition to that area as well.
Yeah, I think that's such an important point there. And you're right that, you know, we have all been very, very physical health condition focused in a lot of the presentations today. And I think that's such an important point to think about. You know, whilst there are many similarities that connect the research that we do and underpinning supportive care needs of many carers, and underpinning kind of challenges that are faced and barriers to carers being able to get care, I think there are some very unique elements and complexities of when you're talking about caring for a loved one with a mental health condition, and or a child with a lifelong disability. So I think there are things that we absolutely need to sort of factor in there, in the interventions we build. And also, you know, how can we maybe leverage some of the work that we're doing, but and adapt it for those unique populations? Because I guess to say one size doesn't fit all. There are probably really unique elements of different diseases and different populations. Okay, anything else? Any other thoughts on big picture wishes?
More streamlined and timely access to relevant services, not just from a psychological, emotional perspective, but even, you know, in discussions about what we were talking about with M&D and just the rate of progression and things like that, and services coming in too late or connection to bereavements. I think there's a whole bunch of issues that carers experience, and it's sometimes it is that the services aren't available or don't exist, but I think a lot of the time it's actually just facilitating those connections to the services in a timely manner and utilizing the services that are already available to actually then support carers. And, you know, in that, I think we would naturally then see some of the gaps that exist. You know, I think about some of the work that I've done, and we actually had a large number of carers of people who are living in regional and remote areas. And in some contexts, it is that the services literally just aren't available. And while there is that need for more, there's also finding a way to find more avenues to connect them to a whole bunch of different things that then can support them in that capacity.
Absolutely. Xiaoxi, you got anything to add?
Yeah, I saw in the chat, I think Monique said respite. That's
Yeah.
also one other thing that's our carers said. Many of our carers hasn't really taken a break since they started caring, and I'm talking about decades of caring. And in terms of respite, that would look like respite of good quality, and by good quality, I mean respite services that recognizes the nuances in care, that builds relationship with carers, rather than having one-off kind of service, kind of oriented logic in mind, to provide carers with the respites that can help them to truly have a break. Some of our carers talked about why bother having a respite service, and this is not a universal, circumstance, but they're talking about I'm just going to be worried all the time if I'm having a respite worker in my caring. So what's the point of doing that? And also extending on the respite point to recognize that carers will end at some point. Carers will have, as we know, many carers have health conditions themselves, and also recognizing that at some point people might no longer be able to or no longer wish to care. I think that's an important part of recognizing carers' rights as human rights. Yeah.
Yeah, 100%. 100%. And I really like that those reflections on carers' rights and I guess carers' autonomy in their role. It's not just an assumed role that someone or it shouldn't be an assumed role that is placed on someone. It's something that's important for carers to be able to negotiate what elements of it they're comfortable with. And I think that links nicely to what Anna was talking about at the start around, what happens, at end of life, for example, and what carers feel comfortable with, being able to support their loved one to die at home, but also what the long-lasting impacts of that can be when you are, doing these roles without that level of support. Yeah, absolutely. I guess one of my little things, I always say that I'll retire when there's like a Medicare item number that could a health professional, so let's say an oncologist or a neurologist or a nurse, someone could put a Medicare item number for speaking with, so carer education, information, and support. Because I think one of the things I hear a lot from health professionals is they really do know how hard it is to be a carer. They know just how challenging it is. They know that carers have their own unique informational needs and support needs. But oftentimes we exist in a structure, in a healthcare system that allows no reimbursement models of that, and therefore they're not quite sure how they fit that into their role and their scope of practice and their responsibilities when there's no structural system that allows for that. And I guess that's something that I continue to reflect on, is how do we get to that point of there being something that makes carer support, embedded carer support in health systems, in social support systems, sustainable. And maybe that's one little piece. So I'm just going to throw my wish out to the universe. Does anyone else have any other reflections or comments before we wrap up for today? No. Well, I am just so grateful for the amazing research that you all presented today. I mean, if I'm allowed to sort of have a few last reflections and tying everything sort of together, I mean, we've really been able to traverse many different conditions today across many time points. So I mean, one of the themes in Sally's presentation was from before diagnosis through all the way to, you know, what Jiaoxi was saying about when caring ends, and then Anna, you know, you were talking about, you know, bereavement. And I think that we've really been able to see that, you know, these unique, complex needs span from, you know, even before diagnosis to when caring ends, either for whatever reason the caring experience ends. I guess we've also spanned lots of different methodologies, which is brilliant that we're looking at carers' needs and interventions from so many different angles. So I guess we've had reflexive thematic analysis, we've had interpretive analysis in qualitative methodology, we've had timeline elicitation, we've had co-design, and we've had hierarchical linear regression. So I think we've been looking at this, and co-design. Did I say co-design? We've been looking at this from so many different angles, and I think that's brilliant. And I think we can collectively learn from the methodologies that everyone is using, and to be able to, you know, prompt us to collaborate more, because there are different expertises that exist within our carer knowledge base and our carer research community. And I guess that exists across disciplines as well. So we've had, you know, sociology, social work, psychology, you know, really spanning a lot of different, you know, fields of focus as well. I think one of my, you know, to finish up, I guess my reflection is that, you know, central, you know, there's many things that are central to driving progress in this, but I wanted to reflect today on the deep importance of uplifting our research capacity, which is all about events like today. So, you know, central to driving, you know, progress in the area is a commitment to and support of researchers and research capacity building. We know that research is so crucial to progress. We need to be able to use research to change policy, to change practice. And I'm so thrilled, you know, to be able to be a part of a program that can bring us together to support early career researchers. And I really do think that, you know, that research is crucial to progress, but that early career researchers are crucial to research. And that, you know, I guess I just wanted to reaffirm my commitment and thank Carers New South Wales for their commitment to early career researchers. So thank you again, everyone. It's been an absolutely brilliant afternoon. I'm, you know, leaving today feeling energized by all of the great research that's happening across the country. And I do hope that, you know, connections can be made on the basis of this. If people in the audience or the panelists, you know, would like to reach out to one another, I'm sure we're all pretty Googleable, but otherwise, I think feel free to contact Francisca or Lucas, who I'm sure will be able to get you in touch with any one of us if people do have more questions or would like to collaborate in any way. I might now hand back to Lucas. I better thank my co-facilitator, Kira, as well before I hand over. Thank you, Kira, for joining us and for, you know, your wonderful wisdom. And thank you also to our panelists who have been brilliant. So yeah, I think I'll hand back now to Lucas to finish us off for the day.
Thank you so much, Rebecca. Thank you so much, Cara. Thank you so much, everybody who shared insights into their research. It was indeed a great session. I saw many links from what was discussed in the morning session around the importance of autonomy, of recognition, the diversity of caring roles, but also the issue and barrier that is faced by carers, as well as our research, which is siloing, not just in the system, be it aged care, be it healthcare, but also for researchers very relevant in disciplines and methodologies. And I hope that today's session really helped, and that the Care Knowledge Exchange more generally helps to overcome this siloing and to get into contact with each other, and that from this contact a move forward can be supported that improves outcomes for carers. That's why we're all here today, and and for your contribution to that, I would really, really like to thank everyone who was involved in today's sessions. This symposium will continue tomorrow morning at 10 a.m. with a session on policy and practice innovations. So we're moving more into the realm of practice, and I hope to see you all there. Thank you so much for coming. It was a pleasure.